I'm Arlene Butz. I'm a nurse practitioner with a PhD, and I'm going to present models of strategies for urban and rural settings. If you have questions, I guess hold them. Okay, I'll try to speak louder. Hold them till after both presentations. I have no financial relationships or conflicts of interest. I'm going to try today to describe one model of care that we have used in some research with inner city children, and I've actually used it in practice, that promotes asthma communication between the family and the provider. I think sometimes that's where the breakdown is. And I'm going to present an intervention to enhance family and provider communication around secondhand smoke exposure. The model that I base a lot of my practice on is the Wagner chronic care model. And I like it because the health system is incorporated in the community. It's really the community that's taking care of our children with asthma. In the health system, you have provider decision support, clinical information systems, delivery system, organizational leadership. I primarily focus on provider decision making because the provider's making the decision, do you step up therapy, do you step down therapy? They need the information. How do they get that information? They get it from self-management, the community, self-management support, community resources and policies. Hopefully, this is my goal, or our goal, is to have patient-centered care and productive interaction. So when that child and family goes into the provider, it's a productive interaction. They get the appropriate medications and they get guideline-based care and improve child asthma. To get that, you need a prepared, proactive practice team. And that's where the provider decision support comes in. The provider needs to know the symptoms that the child's having, but he also needs to know what medicines is the child on, what refills is the child refilling it, what's the adherence, spirometry. But you also have to have an informed, activated parent. So if you have both of those, you get patient-centered care. So that's the model that I'm sort of coming from. If you condense it down, really what I would like to focus on today is productive interactions between the family and the provider. And again, it's the health system. We're just looking at one part, provider decision support, community resources, looking at patient caregiver and self-management, that communication. I think this will become a little clearer once I get into the talk. So the goal is preventative asthma care, and you can't have prevention unless the parent, child, and the PCP, the primary care provider, are all on the same page. So, but the provider needs to know symptom frequency, the child's activity level, the pattern of the rescue and the controller medication use, and how well is the child using the MDI and the spacer, all the device. But how will the PCP know that? He asks the questions, but if the parent's not accurately reporting that, then he's getting wrong information, and his decisions may be based on inaccurate information. So medication adjustment is based on the information that is presented by the parent and or the child. And that's sort of, I guess, the basis of my talk, is we have to make sure the parent relays accurate information to the provider. Overall, the estimation of asthma control, if parents do overestimate asthma control, that results in inappropriate treatment. So if a parent says, yes, my child has his asthma under control, he has good asthma control, the provider may say, well, I can step down my inhaled steroids, or I can pull back on one of the medications. But if that's overestimation, they're going to get inappropriate guideline-based care. Dozier is a researcher in Rochester, New York, who did a study looking at parents' assignment of asthma control, and then asked them also symptoms and missed school days. And 90% of the parents said, yes, my child's asthma is under control. But 50% of those parents, of the children, had missed school, had symptoms on a weekly basis, and the child was using rescue medication on a regular basis. So there's a discrepancy there. And so the discrepancy, she labeled parents who said asthma was good control, but the child's still having symptoms. Those were discrepant labelers. And if 83% of the discrepant labelers were using rescue medication on a regular basis, but if a parent was pretty accurate about, yeah, he has poor control, you know, or he has good control, but, and then there was less symptoms, a consistent labeler, they had less use. So it really is important that our parents are accurately relaying, understanding symptoms and relaying that to the provider. And this is another graph showing the same thing. We asked 199 parents, okay, is your child's asthma under control? And then we asked, how often are you using rescue medication in the past 2 weeks? So it was asked over the same time period. So very few parents thought their child's asthma was poorly controlled, like 23%. But 60% were still using rescue medication. So again, that shows you the discrepancy there. And you've probably all been over the asthma control. So parents are the main communicator to the provider for children. However, school-age children are more and more managing their asthma medications themselves. So I'm suggesting that they should be included in the treatment decisions, not, you know, whether you step up or step down, but like when, if it's a BID dose, when should they be taking that? Do they want to take it before school and after school? Do they want to take it during school? And just including the child in having him relay the symptom that he's having, you might get, you know, a more accurate. But few studies are looking at the content and the level of parent and child communication with providers during the visits. And primarily, the communication is dyadic, they call it. It's the parent and the provider, and the child's sort of like sitting out there. And a lot of pediatric people are proposing that it should be triadic, the parent, the child, and the PCP. They all should be communicating together. So how do we improve this communication of symptoms and medication use? Well, I think we need to teach the parent and the child symptom recognition. And there are studies of, you know, what exactly should you be teaching parents to look for. Like, they need to know, how do you measure a respiratory rate? You know, that's what we do as clinicians, but parents don't know that maybe a respiratory rate of 40 or 60 is high. So maybe they need to be counting, you know, they need to be taught this is a high breathing rate. Also, the use of peak flow, but I know in my practice, children just, they start out using it and then it like levels off. So, but I'm still advocating the peak flow. They need to know symptoms of severe breathlessness, like not able to talk when they're breathing, flaring, retractions. So we started teaching our parents in our studies, you know, these are signs of respiratory problems. You should call your doctor when you see these respiratory problems. Also, you can teach families how to keep track of symptoms and medication use with an asthma diary. I just put, this is one off the web, symptoms, peak flow, and medicine. I have another one that I'll show you later that we're using. It's much simpler. It doesn't have peak flow on it, though. We could add it. So we started using child cue cards because we're thinking that if you cued or prompted a child and a family when they went into the provider, maybe they would be more likely to relay accurate information, and then the provider could make accurate assessments and treatment decisions. So the child cue card, we try to remind the child to talk about the current medications, including problems. Like if they have a bad aftertaste with an inhaled steroid, tell your provider. I mean, even if the provider can't do anything about it, he needs to know what is the problem with medication. We had the child keep a symptom diary. We had them actually say what their activity level was. It was a Likert scale, and I couldn't find the picture. It's the bean pictures. So the on the active side was the bean, on the skateboard, you know, looking very active, and at the opposite end was sitting down, you know, just unable to like do a lot. And so the child, it was 5 levels. The child would circle wherever their level of activity was. And then personal goal, we asked the child, okay, what would you like to do if your asthma is better? Do you like to play basketball, roller skate? and we took a Polaroid picture of them so that they could show the provider, this is what I want to be able to do, and my asthma is preventing me from it. This is my personal goal. So the child would take that in with them when they went to the pediatrician or provider. This is the diary we used. We divided, 7 days, 7 days, daytime symptoms, nighttime symptoms, and we had them so it was easy. They just had to check off the symptoms. If they didn't have symptoms, they were to check none. And that's because if they didn't check anything, you didn't know if they missed that day or they didn't have symptoms. So we had them check none. And then we listed their medications that they were on, and did they take it that day, yes or no. So it's not a lot of detail, but at least it was getting the symptom frequency and the medication use back, like picturesque to the provider. The parent also had a cue card, and this was a one-page sheet called Notes to My Doctor. And so the parent would again relay symptom frequency. Did the child have a recent ED visit, hospitalization, current medications, likes or dislikes, any problems with the medicines, desires for change to my child's asthma management. Again, you may not be able to change it, but we at least should know what they're thinking. Did they want a medication changed? Were they afraid of a medication? And then we asked them worries, expectations, and beliefs about my child's asthma. When we would ask that, we would get a lot of steroid phobia. A lot of parents do not like their child on an inhaled steroid long term. So they'll put them on, but they'll take them off when the symptoms go away. They also wanted to ask the provider, does my child outgrow asthma? Another common problem in the city was, can my child go up and down stairs in the schools? And that's what I learned, that some of the schools have, I guess, 3 levels that the childs have to go up and down. So this is the kind of information we wanted communicated to the provider. And this is what the Notes to My Doctor looked like. It was one-page sheet, and they would just fill it out before they went to the provider's visit. A nurse would come out and help them fill it out in the home. And then we would hand that to the physician and say, here's, the symptoms, the emergency room hospitalizations, medications. So we used the cue cards, we filled them out, and then the nurse would role play with the family in the home. This is how you're going to communicate, with the provider. We'd role play with the child. Show me your personal goal, show me your medications you don't like. And then the nurse would actually accompany the family to 2 of the provider, 2 asthma visits, and they were non-urgent asthma visits, because we wanted to see, did the cue cards help? And also we wanted to know what goes on in those visits. So the nurse was there observing. She was told she was not to be the one, for this study, she was not to be the one to do the relaying of the information, because we really wanted to see, did the parent with that cue card communicate? So the length of the visits, you can see, were fairly long, and some of that may be because the nurse was there. But I actually think that's about how long a visit, 45, to really get all of this information across. So the length of the visits were 56 to 49, but what was more disturbing was, almost all the parents still needed prompted to say, don't you have something you want to tell the provider about your child's asthma? So they were still having to be prompted by the nurse. And then we looked at what was the content of the PCP visit. So most parents and PCP, they discussed symptoms, they discussed the medications, they discussed the personal goal. Activity level was only about 2/3. But demonstrating the MDI technique was less than half. So less than half of the visits, and even if it was like one visit, but less than half of providers were checking the MDI technique. And the guidelines say that should be observed, and it should be observed on a regular basis, even if you think they're doing a good job. And then discussing the medicines that they dislike, that was very low discussed.